إنه ممكن نحتاجه بعدين.
Robert online, can you hear me? Today we will start the first topic in neoplastic disorders, and we will start with blood cancers first of the mask, and solid cancers will be finally examined here. Now, we will start with acute leukemias for blood cancers. We also will cover chronic leukemias and lymphoma, both Hodgkin and non-Hodgkin. So when we talk about leukemia, what comes to your mind? What is leukemia by definition? Yes? Pardon? Bone marrow cells. Okay, good. What else? Yes? That's very good. So when we talk about leukemia, what is the cancerous cell here? It's a blood cell, right? And so according to the type of the blood cell, we classify leukemia into myeloid or chronic or acute. So generally speaking, about cancer, predictably, all types of cancers, blood cancer, solid cancers, soft tissues. What is common in neoplastic disease? What is common? Uncontrolled? Excellent. So normally we have control over the number of divisions. We have control on the turnover. There is a balance between cell division and apoptosis. What is apoptosis?
Cell death.
Programmed, not random, not the process. It's programmed, it's controlled. And each cell has a turnover time. What does it mean? Editing time, okay? What happens in cancer, all types of cancer, that a defect happens because of some reason that now this growth or proliferation of cells is lost. And so the cells start to out of control, divide and grow out of control. And accordingly, they increase in size when we talk about solid cancers, or in count when we talk about blood cancer cells. Plus, they cannot perform the regular function. So, if we have liver cancer, okay, not just liver carcinoma, can the cancerous cells perform the metabolic activity of normal hepatocyte storage and so on?
They are
no. It's only increasing in size, and it's acquiring some abnormal criteria. Like what? Can normal hepatocyte invade surrounding tissue? Can they migrate to distant sites? No. So basically what's happening here is that there is hyperproliferation, but the cells are what? When we talk about carcinoma, they have transformed from normal cells into neoplastic cells, malignant cells, and start to acquire new properties, characteristics that we do not normally find in the normal cells. And this is the hallmark of all types of cancer. And by the way, when we talk about cancer, we talk about more than 100 different entities, types of the disease. Okay? So, when we talk about leukemia, the abnormal cells that are transformed into malignant cells is a blood cell. And they start to divide out of control, and increase in the immature blood cells is found in the bone marrow or in the blood. So when we talk about normal hematopoiesis, all blood cells, all the different types of blood cells, they come from the same mother cell, progenitor cell, which is called a blood stem cell. And where we find the blood stem cells? In the bone marrow. Okay? So this blood stem cell has the ability to differentiate, to grow, to give rise to different types of cells. And so they can either differentiate into a myeloid precursor or progenitor, and this then grow naturally to give you either RBC status or granulocytes, so they are all myeloid derived, or it can differentiate into lymphoid, and they will eventually give you E cells, T cells, lymphocytes, or natural killers. Okay? So all blood cells come from the same stem cell, but the differentiation process is different. Now, what's the difference between the term blast and site? What's the difference between a lymphoblast and a lymphocyte?
And the blast.
So when we talk about blasts, lymphoblasts, myeloblasts, are they functional and mature blood cells? They're not. They still need maturation. They are not healthy functional nodal. They cannot, for example, carry oxygen. They cannot attack tissues like T cells. So when we have leukemia, because of some defect, a problem, the lymphoid or the myeloid stem cells cannot grow into a more mature cells, or the blasts cannot differentiate into the final product, the final blood cell. And so if we have leukemia, what is the hallmark of the disease? How do we know that we have leukemia?
The blast.
So what cell count will increase? The blast count will increase, the blasts will accumulate. Okay? And this is how we diagnose leukemia. We'll talk about it. Now, we can divide malignancies according to patient population. And so we can have pediatric, very common cancers that happen in pediatrics, and we have adult cancers. Now, leukemia, especially acute leukemia, very common in pediatrics. It's a very common malignancy in pediatrics. It can happen though in adults as well. Okay, they can happen here and here. But acute lymphocytic leukemia, particularly, is very common in pediatrics. And most blood cancers in pediatrics are because of acute lymphocytic or lymphoblastic leukemia. As I've explained, in the bone marrow or in the peripheral blood, blasts will accumulate. They cannot give rise, they cannot become mature enough for healthy normal blood cells. And this is usually associated with, generally in a patient with leukemia of any type. We have a classical blood picture. Leukemia comes with anemia, thrombocytopenia, and neutropenia. Why? This is classical. Yes?
Because the immature blasts don't differentiate to mature neutrophils.
Yes. Yes. And the space on the bone marrow is highly occupied with blasts. There is no space for production of other types of cells. So usually patients with leukemia, whether acute or chronic, they have anemia, they have thrombocytopenia, and they have neutropenia. Okay? Now, when we talk about blood cancer cells, these can be found in blood, right? You can just take a sample of the blood and you can count blasts. And they can infiltrate to other organs or tissues. What does it mean, infiltration? To reach into, okay, to go there. For example, do we expect normally to see in normal conditions high count of WBCs and CSF, for example? If it's there, it means there's a problem, right? Now, if leukemia cells can reach the CNS, and if we can detect leukemic cells in CSF, that is CNS infiltration. Leukemia cells can infiltrate into other organs like liver, spleen, skin. We call it infiltration. So the presence of abnormal blood cells, malignant, in tissues or organs, we call it infiltration. Now, in solid cancers, when the cancer cells split from one organ to a distant organ, we call that
invasion,
metastasis. For example, breast cancer starts in the breast. It can metastasize to brain, blood, bone. That is metastasis. not infiltration, because normally they are found in a solid cancer. They were not found in blood. So we call it infiltration. Infiltration means bad disease, aggressive disease. Leukemia is very aggressive. Now, we classify leukemia into 4 different types based on the progenitor, abnormal neoplastic cells, and the degree of maturation. So we divide them into acute, lymphoblastic, or myeloid leukemias, chronic, myeloid, or lymphoblastic or lymphocytic leukemia. Okay? These abbreviations are standard, you have to know. Okay? So in exam ALM, you should know what is ALM. CLM. You have to know the abbreviations. Now, in both acute and chronic leukemias, the cells, the normal blood cell, is unable to differentiate, blasts accumulate, it's unhealthy, abnormal. However, if we compare chronic leukemia cells compared to acute leukemia cells, they are a little bit more mature and more differentiated. However, they are still, compared to normal blood cells, they are neoplastic. Okay, they are abnormal, undifferentiated, unhealthy. Okay? What does it mean, proliferate autonomously? Yes? Without? Yes. You don't need to induce them to proliferate. You don't need to trigger them. They just self-division and proliferate. Okay? So basically, this is what's happening. The stem cells, myeloid or lymphoid, cannot differentiate. The lymphoblasts accumulate, and this will cause eventually leukemia, either myeloblastic or lymphoblastic. Now, as I said, acute leukemia particularly is very important childhood malignancy. Okay? Most leukemia cases, about 80% of leukemia cases, they are ALL. Okay? Now, ALL can also happen in the adult patient, okay, and in the elderly, but less frequently. So ALL is a very important pediatric malignancy. AML, acute myeloid leukemia, can also happen in the pediatric, but less common compared to ALL. AML is a more important leukemia in the adult population, elderly. Now, we have gender difference here. Males, boys, for example, they are at higher risk of acute leukemias compared to females or girls. Okay? So the male gender is considered like, it adds to the bad prognosis of the disease. Okay, what causes leukemia? Why the patient becomes leukemic? What could be the factors? Now, sometimes we have genetic factors. We have certain genes, mutations, changes in the DNA associated with the risk of leukemia, and there are many on this. Okay? Drugs are important. Many anti-cancer drugs that are used to treat certain malignancies, they can cause secondary malignancy. What does it mean? For example, if you give a patient topotecan, for example, what is topotecan? Topotecan, cyclophosphamide. What's cyclophosphamide? Alkylating agent. Daunorubicin, doxorubicin شو هدول؟ حط الكمامة على البق. شو هدول؟ Daunorubicin, daunorubicin, adrenomycin, شو هدول؟ What group? Right? So some anti-cancer drugs, they have high potential to cause secondary malignancies. مثلا, you treat patient with stage 2 breast cancer with AC protocol, anthracycline, doxorubicin plus cyclophosphamide. This patient exposed to these chemotherapy drugs, she has a risk, maybe after 10, 15 years, to develop secondary malignancy, another malignancy because of the drugs, because these drugs are basically what? شو التارجت تبعهم؟ They are genotoxic. Genotoxic, not only cytotoxic. Cytotoxic means what? Cell killing. Cell killing does not necessarily mean genotoxicity, right? They are genotoxic. The target is the nucleic material. And so they can cause genotoxicity to normal blood cells. So they can, on the long term, they can be carcinogenic. So drugs can be carcinogenic. Irradiation, exposure to certain kind of radiotherapy or irradiation might cause genotoxicity and cause leukemia. Environmental factors, for example, farmers, we should look at farming, exposed to pesticides frequently, they have higher risk of lymphoma and leukemia compared to the average population. Exposure to medicine, for example, should look at the science. So we have some factors, and we have also infections. Oncogenic viruses. What does it mean, oncogenic? Oncogenic virus. This virus can cause what?
Malignancy.
Can cause?
Malignancy.
Cancer. Why? Because the virus can integrate the material, the DNA material, RNA, into your DNA, right? So some viruses, they can cause cancers, and the risk is actually high. Like what? Examples of oncogenic viruses, popular examples.
Epstein-Barr virus. Epstein-Barr virus.
EBV. EBV damage, what's the disease EBV causes? Epstein-Barr virus, what's the disease? Mononucleosis, it attacks the lymphocytes, right? It can cause leukemia and lymphoma. 40% of cases of lymphoma, they have history of EBV infection. It's a very important fact. What else? Oncogenic viruses. Hepatitis B and C, they can cause hepatocellular carcinoma. HPV, what is HPV? Human papilloma virus with high risk of what? Cervical cancers, okay? So, what can cause leukemia? There are many risk factors: familial, genetic, environmental, drug therapy, radiation, and so on. Now, to diagnose leukemia, okay, there are different protocols, but we'll go with WHO. What is WHO? WHO?
World Health
Organization. Okay? Now, according to WHO, patient is said to have acute leukemia if the percentage of blasts in a sample of the bone marrow is above 19%. Okay? So, how much blasts we can find in the biopsy or aspiration of bone marrow? It is above 19%, plus clinical picture. This is said to be what? Leukemia. Okay? Now, acute leukemia. Here we talk about lymphoblastic. It could be either B cell or T cell. What is the most common?
B cell.
B cell. So B cell leukemia is much more common than T cell leukemia. However, T cell leukemia is
Aggressive.
worse in prognosis. Sharing prognosis. Prognosis means what? Disease prognosis means what? Pardon? No.
Hard to treat.
The outcomes, what I expect, right? So if I tell you that a patient comes with a stage 4 breast cancer, no more metastasized to the right lung, and a patient comes with stage 1 breast cancer, which one has a better prognosis in terms of response to therapy, relapse, recurrence, survival, cure rate? This is prognosis. Stage 1, definitely not stage 4. Okay? So T-cell leukemia is more aggressive and is usually a risk factor, and worse prognosis than B-cell leukemia. But B-cell leukemia is fortunately much more common. Now, sometimes when we diagnose leukemia, we have to look at certain chromosomal changes. Okay? Why? Because this is first, a risk factor, influence prognosis, can also affect your drug therapy. Now, in acute lymphoblastic leukemia, and we will discuss this again in chronic leukemia and CML, what very important chromosomal change we see is we call it Philadelphia chromosome. Philadelphia chromosome results from a translocation between chromosomes 9 and 22. How do you read a translocation? T means what? Translocation. 9, 21, and 22 is what? Yes, very good. So the translocation is from 9 to 22. Okay? So Philadelphia chromosome positive leukemia patient means there is a T922 translocation, and Philadelphia chromosome is found in the leukemia cells. Why this is important? What happens? Translocations, sometimes they are very serious because they are not random. In other words, when we talk about T922, we talk about a part of chromosome 9. Encoding, it's not any part. It's the part of chromosome 9 encoding ABL gene. The chromosomes carry what? Genes. Genes transcribe expression at the end give us what? Protein. So value, accordingly, the end product of gene expression is what? Is a protein, right? Right? So, basically what will happen here, this segment, this part of chromosome 9 encoding with the gene ABL, translocates and is fused where the translocation happens next to the gene encoding for BCR of chromosome 22. So, this resulting chromosome here with BCR ABL fusion is called Philadelphia chromosome. Okay? Now, why this is a problem? Philadelphia chromosome means highest leukemia. Why? Because the product here, the protein that will come from BCR-ABL, is a constitutively active tyrosine kinase. What does it mean, constitutively active? Constitutive means what? Constitutively active. المرة الجاية بس تيجي متأخرة لفوق. Active all the time. Does not mean activation by a ligand or molecule. It's active all the time. Okay. When it is active all the time, what will happen? What does it mean, tyrosine kinase? Why tyrosine kinases are important targets in cancer? Many of the drugs are tyrosine kinase inhibitors. Why tyrosine? Because they are involved in what? شو يعني tyrosine kinase؟ هذا الإنزيم شو بيعمل؟ To what? To tyrosine and target substrates. Tyrosine signal, tyrosine phosphorylation is a very important blood signal. So when we have a lot of tyrosine kinases with a receptor and non-receptor intracellular or transmembrane, it means the blood signal is huge. And so if we have Philadelphia chromosome, it means that these leukemia cells, their ability to divide, proliferate is huge. And so the disease severity is high. So when we are diagnosing patients with ALL, okay, we have to check Philadelphia chromosome, whether positive or negative, because this puts the patient in high-risk group, which means different treatment. And also we have targeted therapy in case of Philadelphia chromosome positivity. What does it mean, targeted therapy? How is chemotherapy different from targeted therapy? Mean high. twice a year in normal cancerous? Not exactly. شايف كلمة targeted therapy.
يعني اللي بيكون عندهم هذا الانزيم أو
Only and only add this therapy if the target is there. يعني we have a drug called imatinib, BCR inhibitor. The rest of the anti-cancer drugs. ولا لا؟ خدتوها؟ Did you have anti-cancer drugs before in pharmacology or not؟ شكلكوا هيك؟ مش واخدين أنا مش عارفة. أخدتوها ولا ما أخدتوهاش؟ أخدناها ما أخذت التارجت بس الكيمو؟ يس أو نو؟ يس أخذتوه. طيب شو الإماتنا؟ very clear, very important drug. أول تايروسين كينيز inhibitor intracellular هذا أول دواء بالماركت بالعالم. شو الإماتنا؟ أنا عارف BCR inhibitors؟ ماذا ستفعلون في الهيماتولوجي؟ إذا مش الأدوية ما تعرفوهاش ستعرف لازم تعرف الأدوية. Okay? What does it mean targeted therapy? Only if the target is available to give the drug. ALL patient, Philadelphia chromosome negative. Do I add imatinib to treatment? No. Why? The target is not there. Okay. Most leukemia cases, whether chronic acute, they are diagnosed incidentally. What does that mean, incidental? So, I know a case that I handle routine CBC. Routine. Regularly, and كم مرة بنعمل CBC routine before checkup. Few 6 months, it's needed to have CBC basics. Leukocytosis, blast count is high. Check the chemo. Why it's incidental? Because we don't have a characteristic, specific sign or finding. Let's take an example. 90% of breast cancer cases diagnosed by mass in the breast. So if a woman detects mass in breast, it means could be malignant. That's alarming, right? Colorectal cancer, for example, blood in stool, alarming. Urinary bladder cancer, blood in urine, enlargement of lymph nodes, lymphoma. You can doubt these, so there are specific signs. But in blood cancers, usually, we don't have specific signs. Some cases are diagnosed because of repetitive infections. Why the patient is neutropenic, why leukemia, okay? So we don't have something very special in terms of signs, symptoms, presentation of the disease. But if we suspect leukemia, we have to do what? If we suspect leukemia, we have to confirm the diagnosis by what? Bone marrow biopsy. Okay, this is it's invasive, but it is essential to confirm the diagnosis of leukemia. So what happens basically? We take a sample of bone marrow, mostly from the hip bone. Now we can take two different types of samples. The MD ياخذ the solid part, هذا biopsy, we call it biopsy, or the liquid part, and we call it aspiration. Okay, sometimes they do both, biopsy and aspiration. And then this goes to the pathologist. The pathologist will examine, check the cells. The pathologist will tell you that this leukemia or not, and the type of leukemia, B or T cell. And we need these information for treatment. And the percentage of blast to start with. Okay? So we need the bone marrow biopsy or aspiration to confirm the diagnosis of leukemia. Now, any patient with acute lymphocytic leukemia, okay, we need also to take or do a lumbar puncture. Why we do lumbar puncture? What is the sample here we are examining? CSF. Why? This is routine. Leukemia, do lumbar puncture. Acute. Maybe ALL, to be honest. ALL, you must do lumbar puncture, collect CSF. Because we want to check what? Yes, very good. We want to check what we call it CNS involvement. Did leukemia cells infiltrate to the CSF? Is there CNS involvement at the beginning, at the presentation? Did the leukemia cells reach CNS or not? Why we need to know that? Because if there is CNS involvement, we have to treat for involvement. If there is no CNS involvement, what should we do? We have to prevent CNS involvement, so we must do prophylactic therapy. So this step is important. Okay? Technically, and prophylactic therapy. So we have to confirm diagnosis of leukemia through pathology, bone marrow biopsy aspiration. We have to do CSF analysis. And if confirmed, to treat, we have to put the patient in one risky group. Now we have two risky groups. Standard risk or average risk, regular risk, and high risk. We have three factors to decide about risky group. Why we should know risky group from the very beginning? Because the protocols to be used for treatment are different. So, we look at age of patient, baseline WBC count at presentation, and if mutations, translocations exist or not. We have to look at these three together. Okay? Now, a patient age less than 1 year, neonatal, or 10 years or above is high risk. So if you have two patients, two boys, two ALL cases, one has 3 years in age, the other has 13. Which one is high risk? 13. A few weeks ago, ALL was diagnosed in a baby 6 months. 6 ALL. ALL in infants, neonates is really, really bad, very aggressive. They don't tolerate therapy, very toxic. So it's bad. Below 1 year is bad. 10 or above is also bad, high risk. Okay? WBC count at starting. If more than or equal 50 cells there, 10 to the power 3 or 9, this is high risk disease. Okay? Now, if translocations exist, T922 for the different some positive, we have another translocation really important for 11. Any of them will also make the patient what? High risk. So, any of these will make the patient high risk. Okay? Any of these, we should allow any one. If just one of these high risk factors exist, then the patient must be treated as a high risk group. Yes. هذا total WBC count. في leukocytosis, they divide very fast, more aggressive. You know, we have leukocytosis. This is not blast count, leukocyte count. Okay, which means the growth fraction, the proliferation rate is high to start. Okay, and this is bad. Okay. In your textbook, we are now talking about ALL, okay? ALL. In your textbook, the treatment is based on the population. So they divide ALL treatment in pediatrics, young adults, and elderly. So we have 4 groups, and the treatment is different, okay? Treatment is different. Now, we'll talk about ALL treatment in pediatrics. By definition, we stop at what age, pediatric? 16, maybe. does it mean to cure cancer? The first question you have to ask yourself when you plan your treatment for a cancer patient is it curable or not? Can you cure ALL in pediatric patients? What does it mean, cure? Pardon? شو يعني؟
achieve our goal of achieve complete remission.
بس complete remission؟ أنا ممكن يصير معي complete remission ويرجع relapse بعد 6 شهور. لا, what does it mean to have to cure an ALL boy? What does it mean? That the patient is disease-free for at least 5 to 10 years. That is cure. Okay, is ALL curable in pediatrics? Can we achieve this goal? Can we cure the disease? It is highly curable in pediatrics. Highly curable. Okay? Do you know any other cases? صوت مش واضح؟ شو بعمل؟ لا شو شيء؟ وانت حطيته معك. نزلي لتحت إذا صوت مش واضح، قلبي هون فاضي. بس انت بتقعدي باللاست لاين تقولي صوتك مش واضح. هذا. فإذا can we cure ALL in pediatrics? This is pediatrics. Yes, and highly curable. Okay. ALL in elderly, about 60 years. Is it curable?
Yes.
Yes, but the cure rate is less. For example, if you can cure 90% of ALL cases in pediatric, you can cure maybe 60% of ALL cases in elderly or adults. So it's still potentially curable, but at a little bit slower. Okay? What are our goals? Now we have too many blasts to start with, right? And these are non-functional and still immature. They can infiltrate everywhere. We have to control blast count, so we have to kill them with cytotoxic therapy to induce what? Remission. So the first goal is to achieve what? Complete remission in ALL patient. What is the definition of complete remission? I have to make the blast count or percentage below 5. Below 5. Below. Not 5. 5 is not complete remission. Below 5. We said for diagnosis, by definition, it should be above 19, right? Blast count, right? Okay. If patient X comes with ALL, baseline blast count was 25% in Merck, for example. We started our induction. Okay? At the end of induction, we checked bone marrow again, or peripheral blood, and we found that the blast count is now 10%. It falls from 25% to 10, right? There is a response. But is this complete remission? No. It's not complete remission. Okay, from 25% after induction, it goes to 2%. Is this complete remission? This is complete remission. So by definition, complete remission means you have to control blast count to less than 5% with your induction regimen. Okay? Now, if you control the blast count, if you successfully achieve complete remission, patient signs symptoms will improve. Okay? Now, the available current protocols in cancer, the regimen we call it protocol. And protocols usually are composed of many drugs. Now, the protocols we use for treatment in induction, okay, can achieve complete remission in a very high percentage of pediatrics with ALL. Okay? الطبيب الأمدي يعني الدكتور اللي حط الفاونديشن هو مسد الفاونديشن of ALL management was an American military doctor. Okay, he got an order from his boss, find acute leukemia. He started to work on different treatments. He put the foundation of combination treatment. You will see that almost all types of cancers, you don't treat with a single drug. Single drug is not enough. So there is what we call it the foundation of combination regimen in cancer. 2 drugs, 3, maybe 4, 5 sometimes, in the same regimen, in the same protocol. Why? Because if you give only single drug, cancer cells can adapt and become very resistant. So in most of the protocols, whether in blood cancer, solid cancers, you treat with a combination of drugs. We have very few exceptions where you can go with a single drug. Okay? So when you talk about ALL treatment in pediatric, it goes through phases, process. Okay? We have 5 different phases of therapy. It starts with induction. The goal of induction is to achieve complete remission. If you do not achieve complete remission, can you move to second phase, to consolidation, for example? You cannot. You cannot go from one phase or stage to the other unless you achieve the goals in the first one. So if you achieve your goal in induction, if you achieve complete remission, then you can go to consolidation. If not, you have to re-induce another induction. Okay, if you achieved induction, you went to consolidation, but you did not achieve the goals in consolidation, you cannot go to the intensification and maintenance, and so on. Okay? You must achieve the goals before you move to the other phase. So, in order, ALL in pediatric, we start with induction to achieve complete remission, then we go to consolidation if successful. Few cycles of alternating interim maintenance and delayed intensification, and finally, the long treatment time is maintenance. Okay? Maintenance therapy. Meanwhile, this is going on. If there is no CNS involvement, what should we do? Along in parallel, in parallel. At the same time, we should do CNS prophylaxis. We should do CNS prophylaxis. If there is CNS involvement, we have to treat for CNS involvement. Now, collectively, the total duration is, all in all, on average, 2 to 3 years. The longest phase of management is what? Maintenance. Maintenance, okay? The longest duration of management. This is ALL pediatrics, okay? So when we talk about induction, we said we have to induce complete remission, improve the blood picture, and clinical signs and symptoms. Now, we can either achieve complete remission from your first induction, which is usually the thing, fortunately, that happens in most patients, or you might not achieve complete remission. So if we achieve complete remission in 4 weeks with first induction, what we call, how we classify the patient here? Good responder, fast, early. We expect that the cancer cell is very sensitive to treatment, and we expect that the patient will be doing well in consolidation and later phases, okay? Most patients, about 90% of patients, 98% of pediatric patients, they are early fast responders. They achieve complete remission after first induction, okay? Now, few patients, 2%, 3% of pediatric ALL, they do not achieve complete remission after the first induction. So we classify them into M2 and M3. M2 patients, those who do not achieve complete remission, but the blast count is between 5 to 25%. M3, it's worse. We could not get them very down. Blast count is about 25% after 2 weeks, almost 2 weeks of induction. So by definition, these are what? Slow, not very good responders. Why this is important? Okay, here we did not achieve complete remission, and we need to what? Reinduce, right? If we achieve complete remission after induction 2, why this is important?
They need it. Because they need aggressive treatment.
Very good. In the following phases, right? يعني احنا حكينا انه prognosis is determined by how the patient responds to therapy and the risk factor stratification at the very beginning, right? Now, if we have two patients who are average risk, okay, ALL. The first one was an early, so firstly, two students, two boys, acute leukemia, average risk, both of them. One was fast, early respondent. The other was delayed or did not respond. Prognosis would be better where? In early fast respondent. مع انهم لما دخلوا على الثيرابي كانوا both of them were what? Average risk. Okay? They were average risk. So this is important. Why? It tells you about prognosis, sensitivity to treatment, and as Zamilit Kuarat, what's your name? Yeah. They might need a little bit more aggressive therapy, okay, and consolidation and the other treatment. Okay. How we select what is the induction regimen? Now, we said that induction regimen is determined by risk. So we have a standard induction regimen for patients with average risk, standard risk. Induction regimen for patients with high risk. So if the patient is standard average risk, it's a triple therapy, 3 drugs, okay, given together in the protocol. What are they? Vincristine, glucocorticoid, and asparaginase or digasparagase. One of them, okay? Vincristine is what?
Antimitotic.
It's a big catalog, microtubule inhibitor, right? Okay. Why we need a steroid, glucocorticoid? That's immunosuppressive. حكينا عن RA. Glucocorticoids are very good when no? يعني in AML treatment, acute myeloid leukemia, we don't have a steroid in the regimen. But in lymphoid leukemias, okay, come. Why? No. This is أنا حكيت في المحاضرات إنه lymphocytes are very sensitive to steroids. And that's why when we have lymphocytic or lymphoid leukemias as an ALL or CLL later or B-cell lymphoma, usually a steroid, a glucocorticoid, is a part of the protocol. Very suppressive to lymphocytes. And the third drug is asparaginase. What is asparaginase? How it works? This is, it's recombinant in E. coli. Dynamics, mechanism for action. It does what? Yes? Into where? Which amino acid? Asparaginase. It breaks what? Asparagine, right? So, why it's good to use asparaginase in ALL?
The protein synthesis بقل.
Okay. Lymphocytes cannot make their own asparagine, but they are dependent on asparagine. But what asparagine? Exogenous. Can your cells make folic acid?
Yeah.
Can. So you depend on what? Exogenous folic acid. Same thing. It's very important. Asparagine is very important. They cannot make it, so they are dependent on exogenous supply. If you give asparaginase, it will break asparaginase. Asparaginase is not available. Right? So the lymphocytes, the immature blasts, the lymphoids will shrink and die eventually. Now, pig asparaginase is an asparaginase, but prolonged release, okay? Long character. So give one of these, so you have 3 drugs. Now, in high-risk group, patient already having T411, translocation, WBC counts, 15, 17, at presentation, in the highest age group, whatever. From the very beginning, induction should be more aggressive. So we give induction with what? 4 drugs, not 3 drugs. So we have quadruple regimen. What does it mean, quadruple? 4. Okay? The same 3 drugs here, the same 3 drugs plus a 4th drug. This could be an alkylating agent like cyclophosphamide, doxorubicin, methotrexate, cytarabine, antimetabolite, paracetamol. One of them. Okay, so we have 4 drugs. Now, what glucocorticoid we can add to the induction regimen? We have options. You can use Dexa, you can use prednisolone, you can use prednisone. They have in your book, they explain sometimes why it's good to go to Dexa, why it's good to go to prednisone. But basically, any of these is okay. You cannot say that Dexa is better or prednisone is better. You can add any of these to the regimen. Why we have to give CNS prophylaxis even if non-leukemia cells in the CSF? With CNS involvement. هلا في كثير ناس I've seen cases myself على فكرة لقينا كثير acute leukemias في المستشفى. مليان. وبالكلام عن مليان. If they don't control the disease, احنا حكينا فترة the treatment duration is like 2, maybe 3 years, right? Sometimes patients break in the middle. What does it mean? They just disappear. They don't complete regimen. They don't come to hospital for hospital for. They don't. After a few months, they come again with ALL, but this time with more aggressive disease with CNS involvement. Okay? So, in order to make sure there is no relapse with CNS involvement, because if there is CNS involvement, treatment is aggressive and it will be bad. Cure rate will be going sharply down. We have to give CNS prophylaxis. We must give CNS prophylaxis. Okay? So, how we do CNS prophylaxis or treatment? What are the options? We have different options. You can go with intrathecal therapy of combination or single agent chemotherapy. The most commonly used drugs are methotrexate or cytarabine. Okay, RSC. The other name, RSC cytarabine. Okay, antimetabolite. So you can start with this regimen for prophylaxis, and actually this is the standard regimen for prophylaxis. For prophylaxis, intrathecal methotrexate plus minus cytarabine combination is recommended. Now, if we are treating CNS involvement, usually we add to that regimen intrathecal hydrocortisone. So 3-drug regimen for involvement. Now, we said that T-cell leukemia is more aggressive. Okay? CNS involvement is more with T-cell leukemia than B-cell leukemia. So if T-cell leukemia, you can go with a triple regimen, intrathecal, methotrexate, hydrocortisone, paracetamol, or high IV systemic therapy, methotrexate plus minus paracetamol, or cranial irradiation. What we are doing here? Cranial irradiation. Radiation to the brain. Okay, and this is very toxic therapy. This is very toxic. Sometimes we have to do it. Usually CNS irradiation or cranial irradiation for CNS involvement, not prophylaxis. Okay? So these are the options you can give. High dose systemic therapy. Why if we go to IV treatment, we should go with high dose? High dose of methotrexate, plus minus therapy. Why high? Because you need to improve penetration through the blood-brain barrier, right? Intrathecal means what? Where do you put the drug? Into the CSF, right? So this is kind of typical administration to the CSF, right? So if you want to give IV chemotherapy to reach the CNS, you need to go with high dose. Okay? الانترافيكال dose تكون أقل. Yes, of course. CNS. بس إذا أنا قررت أعطيه high dose for IV system therapy لازم الدوز تكون عالي. ولا الميثوتريكسيت مع أو السيد عالي. عادة الIV high dose نعطيها للتيسل لوكيميا. يعني خلينا نقول the standard CNS prophylaxis, the standard is usually intrathecal methotrexate plus minus as the standard. Okay? Let's assume we have a case, AL and pediatric patient, successfully completed induction. We achieved complete remission. Next phase is what?
Consolidation.
Consolidation. Okay. What does it mean, consolidation? Very consolidation. The consolidation is what? Together. In induction, the goal is to achieve complete remission, right? What is the goal in consolidation? Why don't we go to maintenance directly? يعني شو يعني؟ Pardon? يعني Are you sure that your induction regimen killed all blasts everywhere? طيب شو ممكن يكون عنها؟ في شيء بالكانسر بنقول له residual disease. Residual. What does it mean residual? المتبقي. There might be some leukemic cells that survived, right? So consolidation is to consolidate, to make sure that we achieve the goals of induction and eradicate any left residual leukemia cells. It's also short course, few weeks, 4 weeks. We want to confirm the goals we achieved in induction. Okay? So consolidation is cytotoxic chemotherapy combinations to make sure we eradicate any residual leukemia cells or disease. Now, 2 regimens based on response to induction and risk stratification. 2 factors. Now, if the patient from the very beginning has a standard risk and was an early fast responder, a complete remission achieved from first induction, all's well, we go to a 3-drug consolidation, which is vincristine, mercaptopurine, and intrathecal methotrexate. Per week. Short. Consolidation is short. What is mercaptopurine? 6-FP. What family? Antimetabolic. Okay? Now, intensified consolidation, more aggressive consolidation. Either the patient from the very beginning was high-risk group or induction did not go well. In 2 cases, we should go with intensified consolidation. Now, intensified consolidation contains vincristine, asparagines or asparaginase, cyclophosphamide, cytarabine low dose, and mercaptopurine. All these together. فكم دواء هم بالبروتوكول؟ How many drugs in the protocol? because either the disease is high risk or the patient did not respond very nice and induction was M2 and 3 patient, right? So this is intensified consolidation. It's very, very potentially toxic, but we have to do it because we want to kill any left leukemia cells. Okay? Right. We have two phases, alternating phases. عادة ما بيكونوا very high dose cytotoxic chemotherapy, but combination drugs, we call them delayed intensification, interim maintenance. عادة بيكونوا short phases before we go to what? Long-term maintenance. Okay? But we have now different drugs in the protocol. Delayed intensification and then interim maintenance. Okay? Sometimes you give 2 cycles, delayed interim. Sometimes you give 4 cycles, alternating. It depends here. Okay? فهاي بتكون الcytotoxic chemotherapy before we go to long-term maintenance therapy. Right. This is important. Long-term maintenance therapy. We start this after we end delayed intensification and maintenance. And this has to continue for the rest of time. And نفترض مثلا انه I finished my induction consolidation, delayed intensification for 6 months. Starting from that, I have to continue my maintenance for average of 2 or 3 years. When to go with 2, when to go with 3?
Depende على إذا كان
This is the average. When to go with 2, when it's better to go with 3.
لما يكون high risk يكون 3.
High risk. Okay. T-cell disease, right? Name, gender, CNS involvement, right? All these factors imply worse prognosis, so we might like to live longer with maintenance, right? Now, the standard protocol in maintenance, we call it POMP, P-O-M-P. You have to know the abbreviations of the protocols. You will have a lot of protocols coming. AC, RHL, CMF. You have to know what is the drug in the protocol. Stanford, Baker. We need to know what the drug in the protocol. Why? Because MDs do not, they handle names of protocols. They don't tell you أسماء الأدوية in the protocol. POMP, P stands for what? How many drugs do we have? 4, okay? These 4 drugs are methotrexate, mercaptopurine, methotrexate, vincristine, and prednisone. 4 drugs. P here stands for what? المركابتوبيورين. طب كيف P المركابتوبيورين؟ صحيح. شو هو؟ يا رب. Puriphenol. Okay, P. P stands for the trade name of mercaptopurine. Mercaptopurine here is taken orally on daily basis. QD. Well, there is a very special patient education and counseling how to use mercaptopurine in your treatment. So for 2 to 3 years, this boy with ALL must take mercaptopurine every day. Okay? Oral therapy. Now the second drug O stands for what? Vincristine? Methotrexate? O stands for Oncology. Oncology is the trade name of vincristine. And it's commonly used. And معظم البروتوكولات vincristine is referred to as Oncology. Oncology is taken as pulses. كيف نعطي؟ موجود oral vincristine؟ كيف موجود؟ IV. IV. Okay? We give pulse therapy once a month. So this boy should come to hospital once a month to receive what? Vincristine. For 2 to 3 years. Okay? The third drug, methotrexate, M stands for methotrexate weekly for 12 weeks. prednisone 5 days per month, from day 1 to 5. Okay? Monthly. So we have to educate the patient about the regimen very clearly. What happens in most cases, للأسف, شو اللي بصير؟ للأسف. بعد 6 شهور, the boy is good, the family is happy, they disappear. They don't come to hospital, they don't follow up. You call them, يعني in oncology team, في شيء بنقول لهم follow up maintenance. شو يعني؟ يعني إذا المريض ما إجا مش خلاص الله معه. يحكوا معاه ليش ما اجيت؟ عندك سايكل اليوم، عندك admission، في دواء وينك؟ They approach the patient. Why? Breaking the maintenance or breaking the regimen or the cycles can cause what? Relapse, and usually relapse is more aggressive. كثير مرضى ALL pediatrics أهلهم ما بيقولوا يجيبوهم على المستشفى. They are no longer coming to the hospital. They come with relapse and CNS involvement. I know a patient who was a boy, كان عمره 7 سنين. He responded very nicely. Everyone was happy. Excellent response. Very optimistic case. ALL. بعد حوالي 6-7 شهور he disappeared. والstaff, الMD, الoncologist, pharmacist تحكي معاه. يعني رقمه كان عند الكل هو أهله. They even didn't take calls. يعني ما كانوا يردوا. They didn't pick up. رجع بعد حوالي 1.5 سنة. Relapsed. CNS involvement, testicular involvement. In boys, testicular involvement is very bad. Okay, so at presentation or relapse, he died after a couple of weeks. Yeah, he died. فعشان هيك, we must inform and educate the patient. This is a big responsibility. This is cancer. This isn't upper respiratory tract infection. This is cancer. It's malignant. You must maintain a POMP regimen. You must be under surveillance. يعني حتى لو ما في ثيرابي، حتى المريض لو off therapy شو يعني؟ It's not on drug therapy. يجي نقول surveillance شو يعني؟ بتضل تيجي for follow up. Because the risk of disease recurrence is always there. حتى لو كان المريض acute. في ناس بترجع لهم كارسينوما بعد 10-15 سنة. The risk is always there. You are on therapy, right? Now, you are not taking drugs, but you must be under surveillance. Okay? We don't break it. We don't disappear. Because we never miss what happened in the beginning that you started or had it. Okay, it's my mind. Malignancy, you don't know. You are susceptible. فبالتالي البومبي لأنها طويلة it doesn't take 2-3 years. Hospital visits, prednisone, methotrexate. Many patients break in the middle. They can come with relapse, CNS involvement, testicular, liver, skin involvement, it's really bad and aggressive. Okay? بالنسبة للقواعد student tests for the activity, I have them all. Khalid and I will check them and أنت بتسجلي؟
لا
أكيد صفاء أكيد. طيب. So I will check them with Khalid. If I need to correct or fix anything, I will let you know through Khalid. Okay. An activity will be a video material, educational video material. Okay. We will give you topics related to the course. In 5 minutes, I will let you know exactly what you need to do. You have to prepare educational material. And that's why there are too many students in the group. 5 points. If you do really well, you take 5 points. If you don't do really well, you lose 5 points. So this is make it like fun activity. Okay? 5 علامات كويسين ولا لا؟ بالكورس. صح؟ اوكي؟ انت بتاخذ كوزات في علامات خلص حضرتك الامتحان بس راجعتها بس عندكم غيابات، انتوا عندكم ليمت من الغيابات before you are dropped out. صار معي ضرب حقيقي مش قادر اجي، اوكي عندك ليمت، انت عندك غيابات بس مش انه اركن انا ما باجي وبحضرها اونلاين. ممكن زميلك الثاني في القاعه كمان عنده ظرف بس اجا. not fair انه حدا ياخذ ادفانتج عن زميله. اوكي؟ لو سمحتوا اني لا بدي اعوض بدي احضر اونلاين في هالقصص. نو. حنين البدع، هدين مقدادي، ملاك عبد الله، ملك هاني، احمد عادل، عبد الرسول، ايمان عبد الوهاب، اماندا فايز، اماندا، مهند عبد الناصر، ملك عثمان، ملك